Hello, my name is Michelle Langlois, and I'm one of the suicide prevention coordinators here at Jessie Brown VA. And today we're going to discuss suicide prevention, supporting veterans in crisis, and steps for safe suicide prevention. You will learn about suicide prevention signs, risk factors, de-escalation techniques, resources so that you can best support veterans in feeling confident in their purpose and feeling confident um, in your ability to lower risk of suicide. Um, so let's move forward. So, suicide in the United States, let's start there, where we kind of talk about the broader suicide situation in the United States. In 2018, 48,344 Americans died by suicide. On average, there's about 132 suicides each day. And again, this is the general population. Every 28 seconds, someone will attempt suicide. So you're going to see a lot more attempts than you are completions of suicide. So there's approximately 1 million attempts every year, compared to about the 48,000 that we just discussed of completed suicides. Males, we know, are more likely to die by suicide, and females are more likely to make a suicide attempt. Right now, suicide is the 10th leading cause of death. Previously, it was the 11th cause, so it is increasing with the numbers each year. Which is concerning, and so we're definitely seeing more of a public health approach across the country in order to try to address suicide prevention. So let's talk a little bit about veteran suicide. So we know that out of the suicides in the U.S., about 18% of those suicides are completed by veterans. Right now, the most recent data identifies approximately 17 veterans die by suicide per day. That's approximately 2/3 of suicides did not receive VA care. So we know that majority of these suicides are in the community, and so these might be folks that you come in contact with that never come into the VA for treatment. So it's really important to partner with you so that we can work together to really reduce veteran suicide. The age and sex-adjusted suicide rate among veterans significantly increased from 2005 to 2017. From 18.5 suicides to 27.7 suicides per 100,000. And as such, VA has identified suicide prevention as its highest clinical priority. So some data points to kind of point out that have been discovered within analyzing our data is that we know that for female veterans, the rate for suicide is 2.2 times higher than the female, non-female veterans. So that's a significant difference between our civilian females and our veteran females. For suicide rates for our males, it's 1.3 times higher for our veterans over our civilian counterparts. But we know that certain groups that are definitely of concern that we're seeing a faster growing rate are our younger male veterans from 18 to 34 years old. Also our female veterans, that's a group that's their rate for suicide is increasing pretty significantly. So those are two groups that we're noticing the suicide rate is going up. But we do know that if you do an actual count of the suicides of our veterans, 55 over 55 and older, they have the highest count. So we don't want to all dismiss our older veterans. They still have the highest count of suicides within looking at the data. One significant thing to point out is that we know 69% of our veterans will die of suicide by using a firearm. That's pretty significant because a lot of veterans do own firearms, and approximately 30% of veterans report that they actually keep their firearm unlocked and loaded in their home. And so we also, it's also important to discuss, means safety, lethal means safety, and that with the veteran who might be in crisis. Veteran and suicide. So within the criminal justice system, we want to discuss a case that specifically goes along with suicide and folks in the criminal justice system. Generally, although involvement with the criminal justice system can span a number of permutations, incarceration, probation, parole, increased frequency and number of arrests and intensity of justice involvement, these folks are all both at risk for suicide amongst adults. The elevated risk for suicide amongst justice-involved adults overall may relate to the fact that adults involved in the criminal justice system are often confronted with a number of psychosocial stressors, such as unemployment, homelessness and social isolation. Also, a lot of these folks might have a history of trauma, substance use, those sorts of things, which make them more vulnerable. So Justice involved veterans in suicide. We want to discuss the SAVE method with everybody. So the SAVE method is a neat acronym that you can use to kind of think of how we can address and identify signs of suicidal risk. So we're going to talk about that, how to identify the signs, the red flags, as I kind of call them, what to look for. A lot of times people are not going to come out and tell you they're having thoughts of suicide, so you kind of need to look at these red flags. We're also going to teach you how to ask the question. The question being, are you having thoughts of suicide, or having thoughts of death or hurting yourself? And we'll talk about the best way to do that and ask if you're concerned and you see some of these signs of suicidal thinking. B is to validate the veteran's experience. We know that people feel this way for very real reasons, and so we definitely want to validate how they're feeling. And then E is to encourage treatment and expedite care. We know that treatment's effective. It works really well. There's lots of resources at the VA and also at a lot of wonderful other veteran organizations. So getting the folks the resources they need to try to help with this crisis and get them in a better place so the suicidal thoughts are no longer an issue. So signs of suicidal thinking to be recognized. So some common risk factors. People with a history of mental health issues might definitely will have a higher risk of suicides, especially folks that might be struggling with mood disorders such as depression, bipolar disorder, definitely somebody who might have a combination of depression and bipolar disorder. We call it a mixed episodes. Those folks are extremely high risk of following through with suicide. So anybody you know who's struggling with these disorders, they're not stable at the time, these are people to be of concern. But that also includes other psychiatric diagnoses such as schizophrenia, certain anxiety disorders, post-traumatic stress, personality disorders. So these would, if these are not stable at the time, can increase suicidal thoughts in folks. So that's definitely a big risk factor. Other risk factors would be things such as alcohol and drug use. We know that when people if you have a patient you're working with and you see an increase in drugs and alcohol, that is one of the red flags to pay attention to. If they're at their baseline and they're using what they normally use, they're still at higher risk, but it might not be as much of an acute concern. What to look for is somebody who's increasing their substance use, somebody who maybe was sober and had a recent relapse. Those folks are really high risk of suicide during that time of recovery. And so not just people with drugs and alcohol, which makes their increased risk, but there's certain patterns of time that would even make their risk even more so. So to look for those patterns. People who might tell you that they're feeling hopeless. Nothing's going to get better. There's nothing you can do for me. Treatment won't work. These statements people feel comfortable talking about. You'll detect those kinds of hopeless statements, and that's somebody that is giving you a red flag that they might be struggling with thoughts of suicide. People with aggressive and impulsive behavior, people who might have poor impulse control, where they do things pretty much quickly without thinking. These folks might definitely have a higher risk of following through with a suicide attempt if they're having these thoughts. I mentioned earlier that sometimes people in the criminal justice system have a history of trauma. Definitely a history of trauma and exposure to trauma. We have a lot of vets who are, experience trauma. Those folks are higher risk of suicide. So it can be anybody, any kind of trauma. But we know that those folks with that history can be more vulnerable to thoughts of suicide in a time of crisis. Major physical and chronic illness. So a lot of times people don't necessarily think of the medical side. They think of the mental health side solely, but you have people who have chronic problems. They can't do certain physical things that they used to do. It impacts their way of life. It's a lot of losses there for that person. It's difficult to deal with some of those changes. And so those folks are more vulnerable, especially people with chronic pain. A lot of our vets report chronic pain issues. Definitely, somebody who's in a lot of pain, it's not really manageable. They're talking and feeling hopeless about it. Maybe they're drinking or using more in order to kind of compensate for that pain. This is somebody that we definitely want to assess more and maybe ask that question if they're having thoughts of suicide. So people with a previous suicide attempt. So we know that one of your biggest risk factors is this one. People who have actually been able to overrule that ability to want to survive, which is just an instinct in of us as humans, to override that feeling and do something actually to harm themselves next time they do something with an attempt, might harm themselves significantly more and possibly succeed at suicide. So somebody who's been able to kind of break through that part of us as human to preserve our life is definitely risky, and that person is going to be your highest risk person. So if you're working with somebody or you know somebody who has a history of attempts, they're in a crisis again, especially if it's a really serious attempt before, this person is definitely at extremely high risk. So we definitely want to pay attention to those folks. We talked earlier about how there's about a million suicide attempts compared to our about 48,000 completed suicides. And that is why a lot of times people, because it's really hard to kind of break through that desire and that human nature to survive. So sometimes people have to do multiple attempts and do them more seriously each time before they can actually succeed at completing suicide. And so we really, really stress that folks with a history of those attempts are definitely your highest risk group. History of family suicide, or a lot of vets have buddies who they know died of suicide. These people are definitely more at risk, and the data does show that. And any major losses, it could be a financial loss, a loss of housing, a loss of relationship. It could be due to breakup or due to death. Any kind of major loss in somebody's life really can put people into tailspin. It really can create a crisis for them, and those people can feel so overwhelmed that they can develop these thoughts of suicide. So if you're working with somebody and or you know somebody and they had a major loss and they're showing some of these other red flags, that's somebody that you probably want to ask that question. Somebody who has easy access to lethal means. I mentioned earlier that about 30% of veterans who do own firearms have them loaded and unlocked in their home. So that's really a bad situation. If somebody's in a crisis, maybe they have poor impulse control, they're feeling really hopeless, and they have really easy access to something so lethal. So those folks, just by having a firearm in their home, are more at risk for completed suicide. And then people when there's local clusters of suicide in the area, we know there's kind of a contagion effect when people see that, oh, that's a possibility to use this as a way to problem solve the situation. Those folks are definitely more vulnerable. So common warning signs of acute risk of suicide. So some of the things we want to talk about regarding the acute risk of suicide is talking about wanting to die. So again, some people are going to be pretty honest about this with you, and they're going to tell you how they're feeling. But because there's such a stigma in our culture with suicide and mental health, a lot of people will not. They're going to give you these other kinds of signs and symptoms, these kind of secret red flags that you need to kind of look for. But some people will come out and directly tell you. So some people might say, I'm having thoughts of dying, I'm having thoughts of killing myself. Those people, huge red flag, huge concern for that individual. We want to get them to be seen and assessed right away by a mental health provider. Some people will look for ways to die. You find out that they're doing Google searches. That's a common way to look. People looking up. We had a veteran who looked up famous people and how they their choice of means was towards suicide. So this is something to be a concern because they're in the planning stage. They're actually doing something about it. They're preparing. We talked about people who talk about feeling hopeless. There's no purpose in their life. Again, people will feel more comfortable saying those kinds of things. So you might hear those things before you hear somebody directly tell you that they're having thoughts of suicide. People feeling like they're a burden to others. Now, when I do my presentations, I will frequently say, has anyone ever heard anybody say that they feel like a burden? And majority of the people in the audience will raise their hand. This is something that people feel comfortable talking about. I feel like I'm a burden to my family. I feel like I'm a burden to, everybody around me because I can't get the substances in order, or they have to help support me because I can't find a job because of my criminal record, whatever it might be. But that burdensome statements is a real warning sign for you to kind of listen to that, see what else is going on in their life, seeing if this person might be at risk for suicide. And people will say those things out loud. So that is like a nice indicator that this person might be of concern. Maybe I need to ask more questions and make sure this person's safe and get them the help that they need. Again, we talked about increasing of alcohol and drugs. Definitely, if you see that increase in somebody's behavior, that is of concern. It makes them more impulsive. It sometimes creates more depression based on what they're using. It definitely puts them at risk for overdose. So there's a lot of concerns with that increase in drugs of alcohol. Maybe this individual is having more anxiety, or they're feeling more agitated. So you see this kind of change in their behavior and their emotional state. You also might see somebody who's doing a lot of reckless behavior. So as I mentioned before, it's actually kind of hard to actually follow through and do a completed suicide attempt. Sometimes you have to build up. That's why people have multiple attempts. These are not people to dismiss. These are people to be of concern of. But sometimes people will do certain things where they'll tell you, no, I'm not trying to kill myself, but yeah, if I died, I died. So they might have done really risky things with drugs and alcohol that they use. They might drive their car or their motorcycle in really erratic ways. They might, we had a veteran who went into a bad neighborhood where there was a lot of shootings going on, hopefully that they get accidentally shot. So people will do very kind of dangerous things so that they accidentally, if you will, they put themselves in harm purposefully, but so that they don't necessarily have to do the task of ending their own life, but they put themselves in a very dangerous situation where their life could end based on their behaviors. These people are very concerning, and these people definitely should be brought in right away to get them some help. You might see people who are sleeping a lot. A lot of times when people are depressed, their sleep will be pretty significant, but sometimes their sleep is really, really poor. And we see that a lot with folks. Their sleep is poor. People with trauma might have nightmares, and so they're not sleeping well. There is a correlation between sleep, or lack of sleep, I should say, and suicide, even if there's no mental health background or some of these other things. Without efficient sleep, it can really start developing some unstable mental health and thoughts of suicide. So assessing sleep patterns or seeing that someone's not really sleeping is important. People showing a lot of rage. We talked about that kind of like unstable emotions that you might not see with this person. So that could also be rage, talking about revenge. And then, any kind of display in extreme moods can definitely can be a warning sign that this person's definitely not doing well, is in crisis, and might need to have that question asked. So now we kind of identify some of these warning signs, and how are we going to ask that question? It can be uncomfortable, not going to lie. You're probably going to have anxiety, and that's okay. Just know that. But we want you to ask the question very directly. Are you having thoughts of suicide? Are you having thoughts of hurting yourself? Are you having thoughts of taking your own life? They're very direct. There's no wiggle room with them. And so that's going to be really your most effective way. Even though they might make you uncomfortable to ask the question that way, that's going to work the best. What I would encourage you not to do is to ask the question in the negative. You're not having thoughts of hurting yourself, are you? You don't want to ask it that way. The reason you don't ask it that way is because what you're doing is you're telling that person what you want them to answer would be no. And that's really not what we want. We want the honest answer, whatever it might be. Your anxiety is coming out if you ask your question that kind of backwards way. Also, when I ask people what they think about that question, when I present, a lot of people feel it's judgy. And we also know that there's a lot of people who feel very concerned about coming out with these kinds of thoughts and feelings, especially our veterans. The biggest thing I hear from our veterans is if I tell anybody I feel this way, they're going to think I'm crazy. So if they see that you're uncomfortable, they see that you're like, you're not having those thoughts, are you? They feel judged. They probably will lie to you, say, no, man, I'm fine. I'm okay. I'm cool. And that's not what we want. We want an open, honest answer so we can get this veteran the help that they deserve. We want you to use direct words and phrases such as killing yourself and suicide when asking about suicidal thoughts. Again, hurting yourself is kind of vague. That can mean a lot of different things. And it can be a lot of different meanings to folks. So again, that really precise way of asking and directing that question is imperative when you ask somebody that you're concerned about. And then ask a direct question if warning signs are evident. So again, we talked about those red flags, those warning signs we just went over. It's definitely, I'd encourage you to ask when you start seeing these signs that we discussed, and we want you to ask it in a way that allows that person to talk. So, for example, one way I encourage people to ask that question is tell them what your evidence is. So if you're seeing these warning signs that we just talked about, and you're like, oh, I remember this from the presentation, and Joe is displaying some of these things, tell Joe what you see. So, for example, Joe just is getting a divorce. So we know there's a big major loss in Joe's life right now. We know that Joe told you that he is drinking about a half a case of beer a night because he can't sleep. Joe goes out with you and your buddies at work. Every Friday, you guys go to happy hour, but he doesn't drink like that. So we know that the alcohol's increased. We know that the sleeping is poor. We know that when we interact with Joe at work, Joe's affect is more depressed, so we can tell he's depressed. He's going through a major life change with this loss of his relationship with his wife. All these things are red flags. So you say, hey, Joe, I'm so sorry that you're going through this loss with your wife. I can't imagine what that would be like. And that's validating. We haven't got to the V yet, but that's validating Joe's feelings, Joe's situation. The pain is real. I noticed that you've been, drinking more and not coming out with us, on Friday nights anymore. You said you've not been able to sleep. And you seem really, really down. And then what I would encourage you to do, because again, there's the stigma, and a lot of my vets tell me they don't want people to think that they're crazy, and that's the word they use, is normalizing it. You know what, Joe? Sometimes when people go through these kinds of losses, they can get thoughts of suicide. Have you had any of these thoughts of suicide since you've been going through this with your wife? That makes Joe know that he's not crazy. There's nothing wrong with him. He's having a very huge life crisis, huge loss in his life that can contribute to some of these thoughts developing. Normalizing, you're validating how he feels, and you're then asking, are you having any thoughts of suicide? Very directly. With kind of the lead-in with your warning signs, it is more of a natural way of asking that question rather than just kind of throwing that question out of the blue, which is kind of awkward for you and for the veteran, or the person you're concerned about. And as soon as you kind of figure this out, and we want you to ask that question immediately when you're with that individual you're concerned about. So tips to consider. So certain things to consider when you are asking these questions. Like I said, you're going to probably be anxious. So kind of pretend you're not. Kind of fake it, even if you're feeling a lot of anxiety. I'm discussing this with your friend Joe. So try to remain calm, even though if you're feeling kind of nervous inside, try to, on the outward side, look calm, use open body language, closed body language. That's going to show Joe that you're nervous and maybe uncomfortable. Give good eye contact. If you're kind of giving the shifty eye, then Joe's going to know that maybe you're uncomfortable. Maybe Joe's not going to tell you the truth. Let Joe know that there's not an immediate fix, but there's lots that we can do to help him. And so give him some sense of hope. Some people will argue. I know that seems kind of weird. Like, why would I argue with Joe? But the way that would work is if you said to Joe, you know what, Joe, what about your kids? What would that do to your kids if you did something to hurt yourself? That's arguing. It's going to work a lot better if you validate the veteran's experience, saying, I'm so sorry you're going through this. It's just got to be really, really tough to lose your wife after 20 years. That's going to be more effective, showing empathy and that validation when presenting to the person you're concerned about. Some people will say, like, what do I say if he says yes? Like, what am I going to do then? If Joe wants to talk, you might be the first person that he feels comfortable to talk to because you're being direct with Joe, and let him talk. You don't got to say much, just let him vent and provide some support. If Joe doesn't talk, that's okay too. Just make sure that you stay with Joe and get Joe, to where he needs to be or what kind of treatment or a referral that he needs. So either way, follow the veteran's lead. So validating the veteran's experience and feelings. We've kind of talked about this a little bit within how to do that. It's a lot of empathy, a lot of and normalizing what they're going through, showing support, be willing and openly to talk honestly about suicide, listen and allow the veteran to fully express their feelings like we discussed, affirm these feelings and do not pass judgment. Again, a lot of veterans I speak to are very concerned about people passing judgment. reassure them that there is support and there's help. These are things I just brought up, but just kind of reaffirming that these things go a long way with people finally taking that next step to agree to get into some treatment. And so the next one would be encourage help and encourage treatment. And so we want to reassure the veteran that help is available. We don't want to keep the secret. We want to make sure that we get this information out. And don't leave him or her alone. If you're concerned and this person's definitely you're really concerned about this person, please stay with this veteran. If maybe you're on the phone and somebody's in the house, talk to the person at the house so that person in the house can stay with the veteran until we can get that veteran some treatment or get them in. And if you're on the phone, stay with them on the phone until maybe 911 or EMS arrives, because that might be needed. And try to get that person in immediately. Any delay can be very concerning. So if you feel that there's an acute risk that they're going to harm themselves, we need to get them in right away. And you might need to call your local 911. Call the Veterans Crisis Line. We got that as well. We have that phone number right here. It's 1-800-273-8255. That also spells out TALK. And then you just press 1 to get to the veterans side. It's actually the same number as the civilian suicide hotline. The difference is with the Veterans Crisis Line, it is a crisis line. We encourage all veterans to call prior to it getting so bad they develop thoughts of suicide, so that we can really intervene with that crisis quickly so that it never gets to that point. But we definitely want vets who are having those suicide thoughts to call that as well. There is a misconception that you only call if you're suicidal, and that's why it's rebranded as a Veterans Crisis Line. It's a really great resource, and so I encourage you to give out that number to any and all veterans that you work with. You never know when they might need it. And so we never want you to negotiate with somebody who has a firearm. We mentioned a lot of vets do own firearms. Go to safety and call 911 immediately. That's very, very important. If the veteran has taken any medications, cut themselves, or reported any kind of harm when you're talking to them, again, immediately call 911. It's imperative that they get the medical care right away, especially with overdoses. There is a timeline with some of these overdoses that they need to get in quickly. And then if you're not quite sure, you can always call the crisis line in behalf of the veteran too. So I encourage you to do that. This is a kind of a graph of what the crisis line calls look like. We do have a chat for the crisis line. We do have text messaging as well, in case they don't feel comfortable talking on the phone. So there's these other means of communication for our veterans. We can see that there's been about 5 million calls, over 500,000 chats, 184,000 text messages, and then out of that, about 167,000 emergency dispatches. So a lot of vets have told me that they're concerned to call because they're afraid the police will be sent to their home. This gives you evidence that that's usually not the case. A lot of vets call suicidal. We never send the police. The only time that they do send the police is if, or the fire department, is if the veteran asks for folks to be sent to their home, which is actually pretty frequent. They're not feeling stable. They're asking for assistance with that. Or the veteran will not remain safe. They tell you straight out they're going to do something, and we have to make sure that they're safe and they're okay. And then the very bottom, you see the 897,000 referrals. Those are to suicide prevention teams locally. So every day we get a list of folks in our area that is called the crisis line. This is across the country. And then we reach out and we do secondary follow-up calls with these veterans to make sure we get them the resources that they need to help with their crisis, even if the veteran is not eligible for VA services. So it's a really good resource. So we talked about firearms a bit. And so there's a reason we talk about that. I kind of gave you the data on that already. But we want to have a conversation with our veterans, especially who own firearms, because it involves reducing an individual's access to objects or situations that can be used to attempt suicide. It can also be medications or other things of that nature too. It might not just be just firearms, but that's the most dangerous. Environmental safety constitutes the steps taken to ensure the setting an individual is in as free of dangerous conditions. So if somebody has a plan of using A, B, and C, you want to sit there and talk about what can we do with A, B, and C to keep you safe at this time. We know that U.S. veterans are more likely to die of firearm-related injuries. than non-veterans. I gave you the information was about 69% of all suicides by veterans are done by a firearm. To give you some comparison, the civilian population is approximately 50%. We do know that veterans have a high degree of familiarity with firearms. They're more likely to own them. 1 in 2 owns at least one firearm, and 1 in 3 will store a firearm unloaded and unlocked. This graph I think is really helpful. This one to me is really quite powerful. It tells you the time that people make a decision to follow with suicide. Less than 5%, about 24% of suicide attempts. Less than 20 minutes, 48%, and within an hour, 71%. So we talked about folks who might have more impulse control issues. This is concerning when they don't take a lot of time to really think through something like this. And it's really concerning when they have easy access to something so lethal as a firearm. And as you can see, about 85 to 90% chance of fatality if you use a firearm, compared to about 5% fatality of all other means combined. So just removing that firearm temporarily from the home can be really, really helpful in saving a life. The time between when a person decides to die by suicide and they act on the decision is often very short. So we kind of already went through all this. By removing or even just locking up the weapon, it gives you some time there that gives them some ability to kind of change their mind in trying to preserve their life. You still have this thing that's naturally built in us as humans to preserve our lives, and so that is really, really strong, and it usually will override our desire to die. But by putting something a little less lethal in there, in the mix, and then having some time and place to have somebody change their mind and have that kind of desire to live kick in is really important. We know that certain things we've done is, in the VA, we've given away free gun locks. Every VA has them. So I'd encourage you to know that that's a resource for the veterans in your community. Somebody has a firearm, we will ask them to maybe give up their key temporarily to a loved one. They can freeze the key in some water and freeze it in the freezer if they don't have anyone to give it to, so that even if they want to hurt themselves, they have to thaw out that chunk of ice before they can get access to the key, and then it allows that delay. And I got to tell you, most veterans are pretty comfortable with discussing what we can do with their firearm temporarily while they're in crisis. And so there's a lot of creative things people will do in order to kind of keep those items safe. One other thing that a veteran suggested to me once was to store it at a firing range that he goes to, so it's not in his home. Some people will remove it and put it in families and friends' home that have a locked safe. So there's lots of creative things veterans come up with. One woman felt unsafe not having it loaded next to her bedside. She lived alone, so she taped pictures on there of the reasons that gave her reasons to live, which was her niece, so that she wouldn't have to see that if she thought about using it upon herself. So there's creative things you can do, and it is a conversation that probably should be had with somebody who's struggling, who might have access to firearms. Some other resources is Make the Connection. .net. It's a really wonderful resource for veterans who might be struggling and getting into treatment. Maybe they feel everything's hopeless. They can put in their information and all these filters. I'm an Army vet, I'm male, I was in Iraq, I'm dealing with alcohol and sleep issues, and I just lost my relationship. You can put all these little factors in, and we'll pull up these videos of other veterans with these same factors, if you will, and they can see how this person maybe struggled as well and how they actually got into treatment and how they recovered. So it shows a lot of veterans in similar situations that have recovered that might be like them. So it's a really wonderful resource just for your own personal knowledge of veteran issues. It's really great just to see veterans' perspective. So I encourage you to utilize that. Wonderful, wonderful resource. So let's see here. Got a little time, so let's play this video so you can see kind of how this works.
My name is Ryan, and I was in the Army for 12 years. After I got out of the military, after I left Fort Campbell, that was when things really started getting bad. I couldn't find a job doing anything because nobody needed somebody with my skill set. I ended up having a lot of different arguments with my now ex-wife. But the one that really took the cake was we were discussing what to do with a tax return. That whole thing gradually just escalated into how much she hates me and how unhappy we both were in the relationship. And I went and I got my 7mm 08 hunting rifle out. I loaded around, and then I was sitting there trying to figure out and get the gusto up to put around in my head. So I called the 911 operator, and she was the one that actually talked me down. And the officers that they had sent out to the house, one of them was an old Marine gunny, and he's like, I just lost one of my guys to suicide 2 weeks ago. He's like, I'm not about to sit here and let you go out this way. And I was at the VA there for 10 days in the psych ward. When I got back, I realized that I didn't want to be in that relationship anymore. That was not helping me get any better. So I ended up being homeless for 6 months. I was walking because I needed to relocate my camp, and a guy had stopped and picked me up. I was wearing my old fatigues because it's what I had, and carrying a military assault pack because it's what I had. And he said, "Are you a veteran?" I said, "Yes, sir, I am." Over time, I ended up working with him. He did landscaping and fix-it stuff, which was a good experience for me. I was learning some skills. I was learning some skills that I could actually use on the outside. And I started getting hooked up with the VA out in Detroit, which not all of my experiences there were great, but the one experience that was absolutely amazing was with the Operation Enduring Freedom case manager that I had. She was amazing. And over time, if she asked me to do something, if she asked me to make an appointment with somebody or keep in touch with her, I did. And she said, I'm doing as much as I'm doing for you because you're actually trying to help yourself. I used the post 9/11 GI Bill to go to massage therapy school. So I got paid to go to school. And I ended up graduating from massage therapy school with a 3.7. And I went from 18 medications to 4. And I absolutely love what I do. You have to figure out what your next mission is. Nobody's there to give you that next mission. But there are all kinds of people, both at the VA and other veteran service organizations, that can help you figure out what your next goal should be, what your next mission is. Most of the people at the VA that I've encountered are prior service members. They get it. They've been there. You have to be okay asking for help. It's okay asking for help.
That's an example of Make the Connection. It's really powerful, and there's over 400 additional videos on there from veterans and their recovery stories. So it's really a wonderful resource. I mentioned a little bit earlier that with the Veterans Crisis Line, there's referrals that get to the local suicide prevention programs. Every VA has a program. Here at Jesse Brown in Chicago, we actually have 6 suicide prevention coordinators here, and one specifically is geared towards Northwest Indiana, which we cover too. So whatever area that you might be working in, they definitely will have a suicide prevention team. To give you an idea of what that team looks like, they're all staffed with the licensed clinicians. At our program here at Jesse Brown, we're all licensed clinical social workers, but some are licensed psychologists and licensed practice nurses. So we have some mixed, wonderful teams as well throughout the country. Suicide prevention coordinators identify veterans that are high risk for suicide. These are folks that, veterans that come into our radar, if you will, that might be high risk to follow up with suicide. And so we provide additional case management support for those folks, make sure that they have all the resources that they need in order to get them out of that suicidal crisis and get them, as that gentleman said earlier, to their next mission. High-risk veterans are given enhanced mental health treatment, a safety planning, additional monitoring for a minimum of 90 days, which is renewed after that 90 days if the person still needs that added support, which is frequently the case, but not always. And the suicide prevention coordinators conduct trainings for all new employees. We provide trainings such as this one, and happy to be here with our community partners because, as I mentioned in the beginning of the presentation, that we all really have to work together in order to really reduce veteran suicide. A lot of our veterans do not come into us. Some are not eligible. Some are leery of the VA. But we have wonderful community partners out there that we really encourage you to work collaboratively with us so we can really address this situation, this concern about our veterans together. And we're very dedicated in working with all of you. So remember, suicide is definitely preventable. A lot of things that we discuss in my presentations is we talk about myths and misinformation, and one is that people feel like there's nothing you really can do about it. And there's so much we can do about it. It's 100% preventable. There's so much that we can offer folks through the VA, through our vet centers, through wonderful organizations that work for veterans in the community that we partner with. So there's so much that we can do. We have mental health services, vet centers, like I mentioned. We have vet court out there for folks. We got our crisis line. We got our suicide prevention coordinators. All these resources here are here for you and for our veterans to use as needed so that we can really combat this veteran suicides, to reduce it to zero. That is our goal. I think you can. I mean, I think that it's probably more comfortable for somebody who's a clinician. However, sometimes suicide is very vague. Again, there's stigma around it. A lot of times people are not always clear. It's not usually a cut and clear answer. Sometimes it is, but a lot of times it's not. And so one way we can kind of determine the level of risk, do you need to help bring this veteran in for treatment right away, is to see kind of how far they are. So one thing people can say, yeah, Joe, our imaginary patient says, yeah, I have been having some thoughts of suicide, but I'm not feeling like that right now talking to you. I feel kind of better that you're talking to me, but you're still kind of hearing that he had these thoughts of suicide. It might be concerning. So having that next question, because if we know that a veteran does have a plan, they're farther along. So, having to say, do you have a plan? Have you thought of something you do to hurt yourself, Joe? If Joe says, well, yeah, I thought about A, B, C, or D, that allows you to have maybe additional information to know that Joe is of more concern. So anybody with a plan, definitely anybody with intent, are definitely folks that you want to probably take down to the emergency room or encourage, collaboratively to go with Joe to the emergency room to be seen, or to call 911, or to get him into a place where he can be assessed right away by a mental health provider. It might not need to be an ER. But as a lay person, I think it is a question you can ask. If you don't feel comfortable asking it, that's okay too. But I think that especially if you're unclear with what's going on with this individual, because a lot of times people will not be real direct, knowing and finding out if there's a plan in place, that can give you a little bit more information and guide you. And if this person needs to maybe be seen right away, or there can be maybe another appointment set up for this individual in a couple days or what have you, and help them get connected. So I personally think that's okay to ask that question. There's different degrees that you can assess for this. Some might be like, have you ever made a suicide attempt in the past? I ask that question pretty regularly when I talk to veterans. They're pretty forthcoming about that. Now, again, I'm in a different role. However, that doesn't really tell you much, because some people will say it's an attempt, but it really isn't an attempt. So certain things that I asked to clarify a little bit more of that background and that history to see how risky this individual would be, what was the most recent attempt, or what was the most lethal attempt? I also, I think that tells you a lot of information. If the most lethal attempt was that he took a few extra Tylenol at a time he was angry with his wife right in front of his wife, that person might be a little bit less concerning to me. That somebody took a half a bottle of his Prozac and slept through it, and then woke up the next morning and never told anybody until you asked them. And this was maybe, even a couple years later. This person never got help for themselves. They weren't in a situation they could get interrupted by somebody. They didn't save themselves. That's concerning to me. I also like to know about the injuries, which people I think sometimes find is a weird question. But as a clinician, it's really, really great information. And I'll give you an actual example. When I worked in the emergency departments, I had two different examples when training students where they both came back to me different days that the individual told them that they jumped out of a window was their suicide attempt. So I made them both go back and ask what their injuries were, to their horror. And but it told us a lot. So the one individual said that he opened up the window and then someone closed it behind him. So he was with somebody, he was interrupted. He didn't do actually anything to put himself in harm. I don't even know if I'd call that an attempt. I might call it preparatory behavior. I would probably have to get a little more information. But the other person was a female and she actually broke her femur. So that would be an injury that would be indicative of somebody who jumped out, at a higher level. And I worked in a trauma center, and that is an extremely, extremely dangerous way to make a suicide attempt. A lot of those times when people jump from heights, it's lethal. That person had a significantly higher risk for me in my assessment than the person who opened a window, but their reports were the same, that they jumped out of a window to my students. So figuring out injuries, were you ever hospitalized for, when these happened before? Did anybody save you? Did you save yourself? That part of the willing to live, a lot of times people will interrupt their suicide attempts and save themselves. Those are good signs. And so having some information about not just the number of attempts, because some people will say that they've attempted like 20 times, and those people to be concerned, but there's like a whole nother mental health component probably going on with those folks. It's those folks who do some pretty significant things each time, a little bit more up the ante, as I would say. Those are people that I'm really concerned about. People who maybe next time they didn't put themselves in a situation to get interrupted. Those kinds of things are all indicative of what level of risk and how much risk is for next time if they make a suicide attempt. If they say yes, I would encourage them to be seen by a mental health person right away. Sometimes that can be in an intake center. Sometimes it could be staff at your agency to have a further assessment. Sometimes it might need to be in the emergency room. But getting them to a mental health provider right away. At the VA, we do have a walk-in clinic. Most of the VAs if not all of them, are supposed to have walk-in hours. So if you're near any VA, any part of the country, you should be able, in theory, to walk into any of those emergency departments or any VA and be seen by a mental health provider right away. So here in Chicago, we can have them walk into our psychiatric assessment clinic. It's not the ER. And in that assessment clinic, they can get an immediate assessment with no appointment and be seen. But sometimes that's not doable in certain parts of the country or what they're available, it's available for them. So that's where emergency services can be helpful. So, in your community, there are a lot of communities have intake centers and other places so people don't have to go through an emergency room. And of course, mental health agencies, sometimes have crisis services or even mobile crisis teams. In the city of Chicago, we're actually adding crisis teams to the CPD now, which is like a new endeavor. It's not placed yet, but a lot of other places have things like that. So, but being seen, whatever is the best route in your area to have someone be seen immediately by a mental health provider to do further assessment and to determine if that person maybe needs to be hospitalized or to get connected with what level of care was best for them and based on their risk.